A happy afternoon, a happy evening, a happy morning, depends upon which part of the world you are. We all very warmly welcome you to this webinar, and I'm so happy and excited that you all have logged in. I know it's a working day, and I'm extremely pleased that you all are here. Well, today's webinar is Starting Pediatric Enhanced Recovery After Surgery, something that has been in vogue and is in vogue, and practical steps and pitfalls. I know we multitask a lot, and probably some people here are multitasking, trying to reach home as quick as they can. However, this is a wonderful take on multitasking. So let's have our total presence and attention in this particular webinar, because I guess it has lots in store. It would soon be told to you vividly. Let me first share with you certain housekeeping rules. Here is the most important one. After having listened to our speakers, you are going to be intrigued and you would want to ask us questions, and we would be so pleased to answer them. So you can submit your questions in the Q&A box. However, we also have the function where you would speak, you would open your video and the audio and speak to us and actually converse with the speakers. However, since we have lots of viewers, maybe 1 minute per person. Translation. This webinar uses Zoom's artificial intelligence translation feature for live subtitles. Coming to certificates of participation, they will be issued within 10 business days after the webinar. To qualify, participants must attend for at least 60 minutes, and webinar recording shall be published on the YouTube. Let me have a pleasant responsibility to introduce my co-lead and our lead. The chair of Pediatric Committee of the WFSA, which is comprising of all of us, is Associate Professor Serpil, a very dear friend, and she is the chair of WFSA Pediatric Anesthesia Committee, as I told you, and she is from Türkiye. She is Associate Professor, Department of Anesthesia and Reanimation, Acıbadem University. Well, my co-lead today is Dr. Vinicius Quintao, and he is a pediatric anesthesiologist, Hospital das Clínicas. I am trying hard to pronounce this as well as I could. And he is a member of Pediatric Anesthesia Committee of WFSA. I am Dr. Vrushali Ponde, and I am the deputy chair and the lead of today's webinar. So here you go, and I hand over all the reins to Dr. Vinicius henceforth. Over to you.
Thank you so much, Vrushali. So I'm from Brazil, from São Paulo. So hello from Brazil, from University of São Paulo. And I'll share my slides here to present our moderators. So welcome everybody to our webinar. So our moderators for this webinar will be Dr. Adisa Šabanović. Dr. Adisa Šabanović is a subspecialist in pediatric anesthesia with extensive training, including a WFSA fellowship and subspecialization at University Children's Clinic in Tisova in Belgrade. She's actively involved in education and international collaboration, serving as a WFSA committee member, our colleague, organizer of pediatric anesthesia fellowships, university lecturer, and contributor to scientific research, and currently works at the University Clinical Center Maribor in Slovenia. Along with Dr. Adisa, we're going to have Dr. Arti Sharma. Dr. Arti Sharma is a fellow of the American Society of Anesthesiologists, also a WFSA Pediatric Committee member, and an associate professor of clinical anesthesiology, and also the division chief of Pediatric Anesthesiology at Weill Cornell Medicine in New York, USA. So Dr. Adisa and Dr. Arti will be our moderators.
Thank you, Vinicius. Good afternoon to all. First of all, I have to say that I'm very honored to be a part of this journey through ERAS. And as pediatric anesthesiologist, I know how important it is to have a good and quality cooperation with pediatric surgeons. That is why also it's my great honor and pleasure to introduce our first author for Journal Club, Professor Sharif Emil, the Mirella and Lino Saputo Foundation Chair in Pediatric Surgical Education and Patient and Family Center Care in the Faculty of Medicine and Health Science, McGill University, Montreal, Canada. He is also the Associate Chair for Education, Department of Pediatric Surgery, and Professor of Pediatric Surgery, Surgery and Pediatrics at McGill University. Dr. Emil served as Director of the Harvey E. Birdmore Division of Pediatric Surgery at the Montreal Children's Hospital from 2008 to 2024. He also founded and currently directs Canada's first multidisciplinary chest wall anomaly center at the Strinus Hospital for Children Canada. He serves as pediatric surgery specialty consultant and international chief medical officer for Mercy Ships International. Dr. Emil has been active in basic and clinical research, publishing more than 160 peer-reviewed manuscripts and several book chapters on many topics in pediatric surgery. He served as the founding chair of the Canadian Consortium for Research in Pediatric Surgery from 2018 to 2023. His research results have been featured national surgery news and Medscape. Several of his patient stories have been featured on the Canadian Broadcasting Corporation, as well as by the local Montreal Press. He was named one of America's best doctors, as well as one of Canada's best doctors. Dr. Emil has a passion for teaching. He has received numerous teaching awards through his career, the latest being the Education Innovation Award from the McGill University Faculty of Medicine and Health Science in 2022, and the Surgical Teaching Award from the Montreal Children's Hospital in 2023. Dr. Emil has also an active interest in global surgery and has participated in multiple missions to Africa, where he operates, teaches, and lectures. Dr. Emil has written a number of editorials in the lay press and has been an advocate for human rights. In 2012, Dr. Emil was awarded the Queen Elizabeth II Diamond Jubilee Medal by the Governor General of Canada for his service to children around the world and his academic accomplishment in pediatric surgery. In 2018, he received the E.P. Taylor Award from the McGill Alumni Association and the Haley DeBass Prize for Promotion of Diversity from the McGill University Faculty of Medicine and Health Science. In 2023, he was awarded the Montreal Children's Hospital Award of Excellence in Leadership, presented approximately once every decade to an exceptional leader. He recently received the 2024 Donald E. Meyer Surgical Humanitarian Award from the American Pediatric Surgical Association. Professor, please.
Thank you so much, Dr. Šabanović, and thank you for the invitation, and thank you to everybody from the WFSA who has put in a lot of effort and time over the last several weeks to plan this. I'm really, really honored and humbled to be with you all. I see a tremendous amount of expertise, truly intimidating on this call. So I hope I'm able to share a little bit of material that can be helpful to you. Let me bring up my presentation. Okay, are you able to see my presentation okay?
Yes.
Okay, thank you. Right, so I think of, my role in the next few minutes is to really share with you this experience in ERAS that we have had here at the Montreal Children's Hospital. And just to give you an idea of the, let me just see. So I just need to declare that my chair does support a lot of the ERAS work, and so the Mirella and Lino Saputo Foundation actually invests quite a bit of funds in what we do, and I have to acknowledge that. To give you an idea of where we are, I'm actually in a very small office in this yellow building here. That's the Montreal Children's Hospital. This is the McGill University Health Center. So we have a freestanding children's hospital. We have another children's hospital, which is a Shriners Hospital for children. So we have really two children's hospital on our campus. This is the only Shriners Hospital in Canada. It's a pediatric orthopedic musculoskeletal disease hospital. So we're very fortunate to have that. And that's important because a lot of our ERAS programs runs out of the two hospitals combined. Then we have a large adult hospital, which is the Royal Victoria Hospital. And that's also important because I'm sure many of you here know the work of Dr. Franco Carli and Dr. Leanne Feldman, who really have been leaders in the adult ERAS movement, and that's been a great source of mentorship with us. And we also have a very large research institute that supports a lot of our research efforts. And finally, we have a specialized chest hospital. So it's a really multifaceted, large medical center, one of the largest employers in the city of Montreal. So when I think of enhanced recovery after surgery, I like to think of it and like to present it as a disruptor. And many times we see the word disrupt in a negative context, to break apart, to put disorder into something, or to interrupt the normal course or unity of a project. But I think if we consider it in a positive manner, disruption can actually be very healthy for what we do as anesthesiologists, as surgeons, as physicians in general. So one of the business definitions of disruption is to successfully challenge something established, an established business, an established product, an established service by using an innovation that's often new technology, but it does not have to be technology. It can also be a new way of practice, a new business model. And that eventually gains a foothold. So it starts as something sort of peripheral and really becomes something quite central to what we do. And it starts in a marginal or new segment and then fundamentally changes the nature of what we do. And I like to think of ERAS as really a major disruptor. And certainly in pediatric care, that has been very much the case because we, as all of you know, have lagged quite a bit behind our adult colleagues in bringing ERAS to the pediatric world, probably by at least a decade, if not more. So if we think about surgery and anesthesia, I mean, what is the most significant and the most prominent surgical disruptor of our lifetime? And I know many people here may not be too interested in American politics, and I don't know if you know who this gentleman is, but this gentleman was James Carville, probably one of the smartest and shrewdest politicians. And James Carville was guiding the campaign of Bill Clinton. And when Bill Clinton started his campaign, the first George Bush was way ahead by 20, 30 points in the polls. He'd just come out of a successful defense of Kuwait, and people were very up, and people felt that Bill Clinton really didn't have much of a chance. And James Carville had a very, very simple concept: just focus on one single topic. And his famous quote was, "It's the economy, stupid." And of course, we know what's happened with that election, and Bill Clinton became president for 8 years. Well, in surgery, has been obviously minimally invasive surgery. I don't think there has been more of a disruptor in the way things were done than minimally invasive surgery. And why is that? Because it wasn't all about the details of the operation or, the details of how many days you have to stay and all the data. Before all that was generated, it just became very obvious that this had to do with the incision. So if you take a huge incision like that for a gallbladder operation and substitute it for 4 incisions that are, most of them 5 millimeters, you didn't really need a huge argument for this innovation to then start challenging the status quo and take hold. And the revolution, of course, in minimally invasive surgery happened relatively quickly by medical standards because we don't change our practices very easily or very fast. So if we take this and apply it to ERAS, here's a patient I had a couple of years ago who came in with a very large right-sided Wilms tumor. This Wilms tumor was still resectable, but you can see it was displacing the large vessels. It was actually invading the diaphragm and impinging on the liver. And when a surgeon and anesthesiologist often see a patient like that, the entire focus is on the surgery, is on safe surgery, as it should be. But we do not focus so much on what's going to happen after the surgery. And taking a patient like this and disrupting the way we do recovery makes a huge difference. So in this patient, we didn't reinvent the wheel. There was an ERAS guideline published by our colleagues in Philadelphia, specifically for patients with Wilms tumors, where they really changed the status quo of what we do. So they were not putting epidurals anymore. They were not doing thoracoabdominal incisions. They were removing the Foley immediately. They were removing the A-line immediately. And we decided to employ that in this patient. And the patient was ready for discharge on the third post-operative day. And the next patient we did this on was ready for discharge on the second post-operative day. This is not a small, minimally invasive procedure. This is a very significant laparotomy. So I start with this because ERAS is all really about the patient. It starts and ends with the patient. I call that the bookends of what we do. Everything starts and ends with the patient. And it's fundamentally about the patient. So it's not the economy stupid, it's not the incision stupid. For ERAS, it really is the patient stupid. So if we look at the traditional approaches, these are the things that we would normally do for a patient with Wilms tumor. And we look at ERAS and everything is essentially turned upside down. We do not leave an epidural. We do a single shot. We remove the A-line in the operating room. We remove the Foley on the first post-operative day. We minimize narcotics. We give around-the-clock Tylenol and anti-inflammatories and start the patient on diet. This first patient we did was on the first day. The second patient was started on diet immediately afterwards. We all know the definition of ERAS. It's a multimodal perioperative care pathway or protocol designed to achieve early recovery for patients undergoing major surgery and really focuses on these four areas: parenteral analgesia, how we manage IV fluids, lack of mobility, and avoiding post-op complications. Now, the next part of this talk is really to share our experience, and our experience may not be applicable. That is what we described in the paper. We were actually invited to submit this paper by the editor. And I always say that all anesthesia and all surgery is local. You really have to see what works in your local environment, but we often can still learn lessons from each other, even if our local environment cannot exactly duplicate a different environment. So our journey with ERAS really started in July 2018 when this new Saputo chair was established. And the Saputo chair was a surgical chair, but it was a very atypical chair. It did not have to do with minimally invasive surgery or a research aspect. The founders really wanted the chair to revolve around some new concepts, and that was patient-centered care in pediatric surgery, which was still a relatively a novel concept. We didn't know exactly what that meant, and education. And ERAS was a fantastic mandate for that because, of course, ERAS is all about patient-centered care and all about education. So it really crosses the path between these two. Pediatric ERAS is still relatively new. I mean, the very first meeting on pediatric ERAS did not happen until December 2018. So this is still, compared to adult ERAS, quite a new effort. So we early on participated in that. And when we came back from that, we wanted to see what is it that we can start with. And we had published some data. We have a very large chest wall anomaly center. We do a lot of corrections of pectus excavatum, NUS procedures. And, we had been relatively happy with our results, but we actually went and looked at the post-operative pain profiles with Dr. Frigon, who is one of our leads in here from Anesthesia in our pediatric ERAS movement, and we found that we actually were not doing very well. These patients were really having significant pain trajectories. They were often having significant pain after discharge, and even when we looked at them a year later, many of them were still experiencing significant pain. So we knew we had to do things differently. And so we put together an interdisciplinary team of these different disciplines, and we started to work on an ERAS pathways. And we then got into COVID, so things slowed down, but that actually gave us a chance because we were not doing as much clinical work to speed up the guideline and get it moving. And we created patient flows charts and booklet. And really, within a very short time, our first ERAS pathway was ready in 2020. And then we wanted to bring the concept to our department. Our Department of Pediatric Surgery is a standalone department. We're not part of our larger surgical department. And, we have all of the disciplines, pediatric orthopedics, ENT, et cetera. And many of the pediatric subspecialists really had not had any interaction with the ERAS concept. They had not even read anything about ERAS. So we started by inviting a visiting professor, Dr. Kurt Heiss, who was really one of the pioneers in pediatric ERAS in North America. And the concept that Dr. Heiss presented when he came to speak at our grand rounds is that this could be a win-win-win, a win for patients, a win for the hospitals that treat the patients, and a win for foundations and funders who are trying to create something that could really disrupt the care in a very positive way, and that it was also a huge source of education. So one of the approaches we did is to start bringing the stakeholders to go to our hospital foundations and the foundations that support different projects, including the Saputo Foundation that funds my chair, and really putting an agenda that includes all the stakeholders. And amazingly, this doesn't happen very much. So usually you have to reach out to the government and try to convince them to fund programs. But the Ministry of Health in Quebec found out about our work and actually contacted us because there really was no pediatric ERAS work going in the province of Quebec, which is a population of about 7 million people, and really not much in the rest of Canada either. So the ministry contacted us, and that was a huge stakeholder to be able to bring the government on board. And we brought all that together, and we had a large ERAS conference planned, was delayed quite a bit by COVID, but as soon as COVID started to wane, we were able to put this, and we did this very methodically. We wanted to start by something that really grabs the vision and imagination and attention of people. So we put this full-day pediatric ERAS conference that brought all of the stakeholders, the doctors, surgeons, anesthesiologists, physiotherapists, pharmacists, government officials, foundation officials, hospital administration. We brought them all together, and we essentially created this large session. Here you see Dr. Feldman speaking. And one of the big parts of the first session is to bring patients in and have the patient voice be heard. And that's often in any medical meeting. I don't think we do that enough. But in any medical meeting, the patient's voice always rings the loudest. So we had patients who were on our Pectus treatment guideline before ERAS and patients after ERAS. And these are two young men who are talking about their experiences. And it was really remarkable what they were saying and the experience they were sharing with the audience. And we had done a session on where are we in pediatric ERAS, and we had some of the leaders in pediatric ERAS. This is Dr. Mihul Raval, who some of you may know, who's also been leading a big leader in pediatric ERAS in the US. And then we wanted to really not just leave the meeting with kind of like a good feeling of, okay, we've done a nice meeting and everybody had nice things to say, but how can we take this and move forward? So we created a very clear roadmap for where to go. Why has pediatric ERAS lagged behind adult ERAS so much? Well, because it's been very hard to define what a child's recovery is. This is a study we published very recently that looked at families of children who had appendectomies for appendicitis. And we had created some educational materials to share with the family, and we looked at those who had materials or those who didn't, and whether they had the standard education or not. You can see here what happens to families of children who have something as routine as a laparoscopic appendectomy. They lose sleep, they lose leisure, they lose a significant amount of work productivity. So our theme, one of the major themes, is that when we talk about pediatric ERAS, it's not just about how many days a child will stay in the hospital. Is what is the family going to go through? How much society will lose in productivity because the parents have to stay at home, or one of the parents has to stay with a child in the hospital. And that's a very different concept from adult ERAS, where we're really just focused on the patient, getting the patient out of the hospital, getting the patient back to work, etc. So we created a number of potential pediatric ERAS conditions in many of the specialties that are within our department. And where are we now? Well, there's actually just an article published this month in the Bulletin of the American College of Surgeons, and the article talks about how great ERAS is for patients, but how a great challenge also it is to implement ERAS. This is not easy work because most of us are busy clinicians, and a lot of this, when you start it, is not going to be funded or supported by hospital administrations or supported by government grants, etc. So you really have to rely, at least in our environment, when we set in, we really have to rely on a lot of private support. And then over time, we have now progressed to where the hospital has actually created a official ERAS committee that reports to our perioperative committee every third month and has very significant deliverables in where we are with our ERAS guidelines. And you can see a number of conditions here that are progressing through the process. One of the exciting things that has happened is the government has come to us and said, let's use your experience and make this provincial. So our ERAS coordinator here, our nurse coordinator, working with other centers in Quebec, actually created an ERAS guideline for all patients in Quebec who are undergoing scoliosis surgery. And this has become a provincial protocol in implementation and gathering down data, not just on a hospital level, but throughout the province. Pediatric ERAS is also still very young. Many of you may have gone to ERAS Society meetings, and the pediatric group is still very small. So we've been very active in the ERAS Society on the pediatric level. And I currently lead an international group that has a very, very ambitious task of creating, there's only one Pediatric ERAS Society guideline so far, and it's for neonatal abdominal surgery. There really are no other guidelines for pediatrics if you go to the ERAS Society website, and there are very few ERAS protocols for acute care surgery in general. And of course, we know that the most common acute care surgery in children is appendectomy. And yet there's significant variability in the way we treat that. There's a lot of over-treatment, there's a lot of under-treatment, there's a lot of poor resource utilization. So we're getting very close now to completing the first ERAS Society endorsed appendicitis guideline working with the ERAS Society. So if I may summarize the message of the paper, it's called Strategies and Themes. What are the strategies? Well, looking for opportunities. Sometimes all it takes is really a spark, somebody interested in a certain area, or a parent whose child may have had a rough recovery who really wants to invest in that, etc. Look for partnerships. Who else can come aboard? Is it another hospital? Is it another department? Is it another group within your hospital that's interested? Look for stakeholders, and it's really important when you move forward that this is not done in silos, but to really bring everybody around the table and really stress the idea that this is a win-win-win. And you don't go from nothing to, 6 ERAS guidelines tomorrow. It's really about incrementalism. It's building what you can at the pace you can to get to a better place. With us, we started with chest wall because that was something obvious. We had a large group. Patient engagement. So we have patients involved in all of our ERAS guideline creation, monitoring, etc. And finally, what we all want to get to is a culture change so that we're not just focused on the operation and the anesthetic, but we're focused on what happens before, during, and after to the patient. And the themes really that we keep emphasizing as we, even in our hospital, we've been doing now for a few years, because there is a lot of memory loss that can happen, is that this is all about education. And if we talk about patient and family-centered care, which everybody wants to talk about, we all talk about that, but what does that really mean? Well, ERAS is a very practical way of actually delivering patient and family-centered care. By definition, it decreases variability in care, so it represents high-quality care. It is a positive disruptor. Probably since the introduction of minimally invasive surgery, there has not been such a disruptor in anesthesia and surgery. By definition, it's multidisciplinary, and the concept that a child's recovery is a family's recovery. So thank you so much, and if there's time for questions, I'm happy to take some questions.
Thank you a lot, Professor. Thank you for this great presentation. Our first question for you is, during the development of ERAS in your institution, what was or still is the biggest problem in its implementation? Let's say, as you mentioned in your article, Surviving China show what their biggest problems are. So is it finance, resistance of colleagues against innovation, work techniques, protocols, politics?
Yeah, it actually, resistance is the best way to put it. I don't think this is a secret to anybody. Changing practice is difficult. And even when we see definitive evidence, that change in practice makes a difference, it's been estimated that it could take up to 10 to 20 years for a practice to actually change. So for surgeons, especially in many multiple specialties who do things like tonsillectomies, where most patients will go home the same day, the concept that we should look at ERAS in a tonsillectomy patient was very unusual, because what sort of recovery I'm going to look at? And this is where we were introducing the concept. It's not just about a patient going home. It's what happens to the patient when they go home. How many of those patients have to stay with their parents for how many days? How many will end up coming back to the emergency room and using more resources? So that is the biggest challenge, and that has to be done, yeah, politically and diplomatically, so that people don't feel they're being forced to change. And one of the best ways to look at that is to do historical reviews. You look back at your own records and you see, how many of our tonsillectomy patients are coming back, how many of our hernia patients are developing large hydrocele, et cetera, et cetera. And you can look at your data, and often people are quite surprised when they do that. They think, oh, we're having fantastic outcomes. And then when you look at your data, you realize, oh, there is a significant potential for improvement. So that we found is the healthiest way to actually start changing people's minds. But by far, resistant to a change in practice is the biggest challenge. It's actually not funding or a lot of the other things, but it's that resistant to practice change.
Yes, thank you. And that is why my other question is, do you also monitor statistical changing during the implementation of ERAS protocol? In what way do you confirm the success of the program, apart from studies, of course?
Right. So this is challenging in pediatrics, because the one thing in adults that people look at is length of stay. If you look at the colorectal ERAS literature, it's all about reducing the length of stay from 4 to 5 days to, 2 nights or whatever. And same applies across the board. So we try to convince stakeholders that it's not just about the length. A lot of the ERAS protocols have actually, show a reduction of length of stay by a day, which is good, but it's not impressive. So it's really about the patient experience and patient-reported outcomes. So what we're trying to do now as we implement is we go through a process where we create the guideline. Then when we get into the implementation phase, we go through a process of what are the outcomes we're going to look at. And we try to emphasize in pediatric care that it's not just about length of stay. It's about the child's recovery to a baseline. It's about the parent. When is the parent able to go back to work, and so on. And that's some of the things. Those are some of the things we're now monitoring. Is that in addition to the outcomes we all look at that we're used to look at, we're looking at the number of patient reported outcomes. And luckily in pediatrics, there is a very good instrument called PedsQL, which I'm sure many of you have used and are familiar with, where we don't have to reinvent the wheel, where we actually can get some very good patient-reported outcomes as part of our protocol. And we're actually even doing that now with our appendicitis work. We're looking at clinical outcomes, we're looking at resource utilization, and we're looking at patient-reported outcomes. Those are the 3 categories we track.
Great.
Professor Emil, if I may ask, is there any particular difference between the way you would pick up and choose parents or families, or prepare them for ERAS so that things go smoother?
We offer to everyone. So for example, now we do cryoablation for and that's the other thing I wanted to say is that ERAS is dynamic. We do cryoablation now, like many people are doing for NAS procedures. So we have changed our ERAS protocol again now to bring cryoablation online. But one of the things I think that is important in starting an ERAS movement and implementing it is to really make it universal. So essentially, once we identify a condition, so now we have scoliosis, we have chest wall, we're working on the tonsillectomy, we're working on the appendectomy. We have it available to all, and we give our educational material to all. For the patient who are having the PEC test, they come to the pre-op clinic, they meet with the nurse, they meet with the anesthesiologist, they meet with the physiotherapist, they meet with the ERAS coordinator who goes over their expectations. And setting expectations is very, very, very important. That is a big part of the ERAS pathway, is to make sure the patient understands not just the expectations of recovery, but the expectations of themselves, how are they going to participate? And that's another very radical concept in ERAS, is that the patient is a participant, just like the physician and the surgeon. A patient is just an equal participant. We actually have a study going on now that we're very excited about, where the patient and the family gets to document in the medical chart. Just like there's a section for physicians and pharmacists and nurses, there is now a section for families, and they actually daily get to document their questions, their concerns, etc., in the medical chart, and it's looked at by the physicians every day.
Yeah, but what if I'm a parent and I am not too comfortable taking the responsibility of my child at home with especially, say, pain management, because we often see such things here. So,
Yeah, and that's very
am I
culturally
the right
related.
family to go under ERAS?
Yeah, yeah, and that's a great point, and this is why I said like all surgery is local. You know, when I was a long time ago when I was quite young, I introduced laparoscopic cholecystectomies in Nairobi, and there were only 2 surgeons at the time doing it, and very expensive to get it. So we did it in our mission hospital, and you know the whole idea is that we wanted to get patients out the next day. We were very excited that they didn't have to stay in the hospital for a week after cholecystectomy, and patients were not happy. They were like, wait a second, I'm having surgery. I need to stay in the hospital and have my family wait on me. Like, I don't want to go home and do this, you know? So you have to be culturally sensitive when you do this. But overall, I think in general, uh, patients still prefer to be in a familiar environment. Maybe they don't prefer it to happen as quickly in some places as another, but I think overall the ERAS concept is actually quite popular, I have to say. And we're in a very, very multicultural city in Montreal, but we don't find that there's any specific population that does not find this, you know, useful or helpful.
We have a question about nurse coordination. So in your article, you wrote about the role of nurse coordinator. Can you please tell us something about it?
That is extremely important. So one of the things that has happened when we partnered with the government is they actually gave us funding to hire a pediatric ERAS nurse coordinator. It made all of the difference because you need somebody looking at the big picture. And us as, you know, specialty anesthesiologists, surgeons, we are not able to do that. Our Justine, our nurse ERAS coordinator, is actually the chair of our ERAS committee. It's not a surgeon or anesthesiologist, it's the nurse. ERAS is all about nursing, and having a nurse coordinator who's then able to engage the nurses is really, really important. I would say it's very difficult, if not impossible, to do without a significant nursing leadership.
Thank you. Vrushali?
Yes, we have a minute more. Any questions from the audience? I know we're following your questions on the chat box. Any experience, Professor, that you have had in pain management? I know it comes from our domain, but I just want to know it from your angle.
Well, I would say there are significant trends, and I'm sure there are people here with far, far more expertise, but
Yeah.
working with our anesthesiologists, the significant trends, I mean, that's not a trend. We've been doing it for a while now. We're really moving away from narcotics to the extent possible. We have not eliminated them
Yes.
completely. But the other major trend is we're moving away from epidurals. And I know that's, you know, every time I go to a ERA Society meeting, big debates and big discussions. And for a while, and I, you know, been practicing for 25 years now. So certainly I've seen epidurals make a big difference to a patient, and they still have great roles. We just had a very, very difficult laparotomy last week when I was on call, and really this girl's recovery was significantly improved by having an epidural. But routine epidurals we're not using now. And like I said, for our Wilms tumor patients, we're no longer using them. And we have amazing recoveries in some of these patients with quadratus lumborum blocks, with one-shot epidurals.
Yes.
And then, so those are the trends I'm seeing.
And that's exactly what I wanted you to say, and you said it. Fantastic. Yes, we have perfect regional blocks these days with additives who do the job. Well, anyway, so yes, Adisa, over to you too.
Yes, this is an interesting question, and I think it's a general problem. How can we adapt ERAS protocols when facing socio-economical challenged population? So I think it is one of
Yeah,
them.
so I mean, again, this is where it's very hard to comment because every system has its own. But the one thing we have to work in with hospital administration is to show that you could have an upfront investment for a significant return. And a great example of that has been cryoablation. In our system, it costs $2,000 per patient to do the cryoablation. But our average hospital stay has gone from 7 days to 1 night. So you can see that the savings, but to get the hospital to buy the cryoablation equipment and to sign the contracts was not easy. But they realized, okay, this is an upfront investment and we're going to make a huge difference. We have the same issue with the NISQIPs. A lot of people here are familiar with the NISQIP P in pediatrics. So it's an upfront investment in hiring nurses, but you can identify areas of poor outcomes that cost you a lot in your hospital that you then get a lot of return. So that's not something always easy to convince an administrator that they need to invest upfront to get a return. But it's just something you have to keep drilling down, because that's really the truth, is you invest and then you get often significant savings back.
Thank you, Professor. I've gotten a lead from our Rosa, who's actually handling the timings. We need to go over to next. So over to Aarti. And may I request the speakers to look into the chat box so that they can answer the questions posed.
It is my pleasure to introduce Dr. Christian Taylor, who would be presenting the second article for today's journal club. Dr. Taylor completed his medical school at University of Oklahoma College of Medicine. He then had residency training in anesthesiology at Vanderbilt University Medical Center. After finishing residency, he went on to have a pediatric anesthesiology fellowship at Children's Hospital, Colorado. After a few years of private practice, he transitioned to academic practice at Children's Mercy Hospital. Currently, he is an associate professor of pediatric anesthesiology at Mercy Children's. He serves as a department champion of Quality, Value, Safety, and Patient Experience Committee at Mercy Children's Hospital. He is also a creator and co-director of Continuous Quality Improvement Program. He also serves as Associate Medical Director for Children's Mercy Cardiac Anesthesiology Service. He holds many society memberships. He's a member of Society for Pediatric Anesthesiology, American Society of Anesthesiologists, notably serving as a delegate in the ASA House of Delegates. On the ASA committees, he serves on a committee on pediatric anesthesia, patient safety and education. He is a member of Missouri Society of Anesthesiologists, ERAS Society, and holds a National Medical Honor Society Alpha Omega Alpha Medical Society membership. Over to you, Dr. Taylor.
Thank you for the introduction, Artie, and thank you all for joining us today. I'm just going to pull up my presentation, make sure that it starts sharing. And can everybody hear me?
Yes.
All right. So my name is Christian Taylor. Welcome. I'm in Kansas City, Missouri. And I was asked by Artie and the organization to present today about an article that was presented or was published a few months ago in the Journal of Pediatric Anesthesiology. It was titled "Error Traps in Developing a Pediatric Enhanced Recovery After Surgery Program." And I also want to give credit to my co-authors and collaborators, Dr. Emily Weisberg, Nicole Doyle, and Todd Glinsky. So what do we know about ERAS and where are we going? So ERAS, or Enhanced Recovery Pathways, we use different terminology in the literature. It was first adopted in the adult population and are widely utilized today. They have shown tremendous outcome improvements such as earlier discharge, improved pain control, decreased cost, and increased patient satisfaction. However, ERAS adoption in the pediatric population has been lagging behind. There is less published protocols and outcomes data in the pediatric literature. Overall, the body of evidence is less robust. In fact, the ERAS Society has only one pediatric-specific pathway for neonatal intestinal surgery. That being said, pediatric enhanced recovery pathways are starting to increase in prevalence and represents an exciting time for those of us that are involved in this hard work. I will say right off the bat, just like Dr. Emil said in his presentation, which I really appreciated, was that this is really hard. It's hard to implement. There are many barriers that can impair its success and multiple phases of the process that can present problems for you along the way, from designing it to implementing it or maintaining it. Next, ERAS should represent the culmination of ideas from a multidisciplinary team. That team will not only be responsible for sharing the vision and educating others, but also must measure the results and identify ongoing barriers. They must share those results with everyone who is involved with patient care, and even share the results with administrators, demonstrating the value that this brings not only for patients or for the clinicians, but to the hospital system. In this paper, we use the terms error traps, but really these are lessons learned from the mistakes that we made along the way, and we wanted to share those with our audience members. Error trap number one: do I have the required cultural framework of support to successfully implement ERAS? It might seem easy, but this is really more than just making up a protocol for others to follow. Do my leaders and administrators support this idea, which takes up time, resources, and money? As Dr. Emil said, this is a huge upfront investment with delayed results, or those results take time to show improved outcomes. Do my colleagues believe that any of this stuff makes a difference? If they don't, why would they be invested to do their hard work to make it a reality? Be ready to face resistance when you present ideas about an ERAS pathway. It happens everywhere and it can't be cured overnight. Organizational readiness for change is a term that I like to describe the integration of these value assessments that lead to people either helping or hurting you in implementing the pathway. If you achieve buy-in from your colleagues and nurses and surgical teams and are all on the same page, then you will achieve great things together. But if any part of this puzzle is missing, then failure is more likely to occur. There are a few different ways to start the process of ERAS if the environment is supportive. Dr. Emil presented a very educational publication on how his department identified ERAS as a strategic initiative and started on a campaign of education and implementation on a wide scale. That requires excellent leadership from the top to be able to do it that way. In our institution, while we do have supportive leaders, the environment at the time, we were a private practice institution. And so the administrative support and some of those other elements made it a little more difficult to have it from a strategic angle. So we had more of a grassroots way of starting it. We started off with a narrow pathway and kept the scope narrow. And then we built up our ERAS program from that first protocol, and then eventually surgeons noticed what we were doing and wanted to add their own pathways into the system. In any case, successful change agents require frequently utilizing Cotter's 8-step model for change as a roadmap for success. I would also add that I would say it's important to utilize the resources that you already have in your institution. Do you have a department that can help with quality improvement or evidence-based practice or implementation science? If you do, utilize these resources. And also, I was going back to saying about how we started in our pathway in our institution. We had an it really started with just a chance conversation with a surgeon in the OR who was starting a bariatric surgery program. And at the time, I had previous experience in residency with adult bariatric surgeries, and I told him about our experience for starting ERAS as a resident, and that's how we brought it to our hospital. Error trap number 2, engagement of key stakeholders. So you didn't involve the people that mattered. That's a mistake, as an ERAS pathway can't be designed from only the prism of a single surgeon or anesthesiologist. It takes the wealth of knowledge, experience, logistics, and perspectives from a team to not only design it, but also to implement it and to monitor its implementation. When you do not include a multidisciplinary perspective, then buy-in and ultimately compliance will decrease. I have on the right a picture of a sample key driver diagram that helps to organize the vision, the goals, the important teams, their roles, and their expected tasks. Using this framework, the champions are responsible for educating their respective peers and building the coalition and to set expectations. Error trap number 3. You failed to notify your frontline staff. Yes, you probably shared an email or had a conversation or a reminder about starting a go live date for a pathway. But on the next day, somebody forgot. Lack of awareness by frontline staff is a huge barrier. I can't tell you how many times that I've heard someone say, I didn't know that this patient was an ERAS patient, or I couldn't find the protocol, so I didn't know what to do and didn't do it. Other times we have made the pathway eligibility too confusing so that nobody can predict whether a patient is an ERAS patient. Sometimes one service has an ERAS pathway and another service does not, and this is for the same procedure. That's confusing. So sometimes we design it in a way that is hard to be followed by our colleagues. We are also at an academic medical center with constant turnover or new rotating residents, fellows, or even faculty. This churn leads to lack of awareness on a continuing basis. The solution is to have constant reminders and updates in communication. We start our communication process early. When the surgeon schedules a surgery for a patient, a special ERAS reminder gets put in the scheduling notes. When a patient goes to our preoperative clinic, a special ERAS comment is placed in pink at the top of the pre-anesthetic note, and so that can be pulled up on the day of surgery, and the person who is reviewing the note will know automatically that that patient is an ERAS patient. On our OR tracking board, we have a little ERAS checklist icon that everybody can see. These small visual reminders really help increase awareness. The next step was to make the protocol easy to find. On our desktop, we have a hyperlink that we all have in the OR. We can easily click on it and show exactly what we need to do. And we make those simple and easy to follow. And here is just a few examples of what happens when we click on those links and what's handed out to the patients. On the left is our preoperative patient education sheet. So this is handed to patients either by the surgeon at the time of scheduling of the surgery that sets expectations for the family, or it kind of introduces them to ERAS concepts and what their role is in the process. And this is also discussed again at our pre-anesthetic consultation. In the middle is kind of a sample of our pectus excavatum repair surgery pathway. We don't have a long narrative explanation of what we're doing in the OR. We try to keep things quick, easy to read, and easy to follow, and keep it simple. And then on the right is a different one for our cardiac surgery patients. Again, we keep the format relatively simple. It's goal-based and principle-based. And also, I would add that we also attach QR codes to our documents so that if patients don't have a way or they're handed a print off, they can access it digitally, and opens up other ways to read it, such as the language that they prefer. Error trap number 4, you don't collect or share data. That's a mistake as well. But how do you know if people are actually following it? How do you know if it's making a difference? Well, you need to measure your outcomes. It's an important element for measuring efficacy or making sure people are following the instructions. It's really important when you need to improve buy-in from your skeptical peers. It helps catch problems with implementation or unintended consequences. And finally, my favorite part is sharing positive outcomes with your peers. What better thank you to them is there than when you show them that it does in fact make a difference and you appreciate their hard work and investment. In ideal scenarios, real-time automatic collection is needed. Take advantage of your EMR or informatics system to make it streamlined if possible. And the data needs to be synthesized into reports that you can interpret and share with colleagues. At our institution, we use dashboards to provide quick status updates of our ERAS pathways. Air trap number 5. You set the go live date for the pathway and simply released it and moved on to the next project, thinking that it would just take care of itself, everybody would follow the instructions, and there would be no hiccups. That's also a mistake. You really have to look at these pathways as living documents. They're subject to critique and change and further optimization according to lessons learned and important feedback that can only happen with ongoing review. At a minimum, you should be measuring compliance in a key goal metric. Your team should review this periodically and seek ways to improve an aspect of it. Then you should seek out your peers who are doing the day-to-day work, asking what are the barriers, what can be done better to improve the system. Seeking feedback can be extremely helpful. Share with them the outcomes and help reinforce the buy-in once it's achieved. We call it maintaining the momentum. And finally, share it with the world through the literature. We can all benefit when we share excellent ideas. And lastly, I wanted to end on a kind of a comedic note about, as Dr. Emil said, the resistance is a major barrier when starting from scratch. And we've heard so many comments at the beginning about skeptical peers and the process and asking if it really mattered or if we really needed to do this. So I just wanted to share a few comments that we used to hear a lot when we first started. And a few of them were comments that pointed out deficiencies in the way we were implementing it, and we made changes to improve it. And a couple examples are these. First comment, the anesthesiologist said, I didn't know this patient was an ERAS patient. A surgeon had said it as well. This is an ERAS patient. And that's always funny when you hear that when you're doing a procedural timeout. Another skeptical colleague says this isn't real ERAS, as in it wasn't endorsed by the ERAS Society. So it can't be official or scientific in any way. Another anesthesiologist said he couldn't find the protocol, so we didn't do anything. Again, those led to changes to where we were systematically removing excuses by making those notification tabs and icons and putting the protocol on our desktop in the OR so that nobody can say, well, they couldn't find the protocol. And another one was an anesthesiologist said, since this patient can't receive medication X, then I just went ahead and didn't do any of the other elements and threw the whole protocol out. Again, it's not about complete 100% compliance. Every little step in the pathway adds value. So if one medication is contraindicated, don't give up on the rest of the elements. And another colleague said that this is really cookbook anesthesia and it's not good anesthesia. Why can't we be doctors and give individualized care? Again, resistance, not wanting to change, feeling like a loss of autonomy. Those are very familiar themes along the way. One time I was discussing adding an ERAS pathway for a specific type of surgery, and the surgeon told me, we already do ERAS every day. We don't need to have a formal pathway to do this. Again, these are things that you will hear when starting this program. Another anesthesiologist said, we are just training our replacements. And in the United States, we work alongside anesthesiology associates and certified registered nurse anesthetists in a care team model at our institution. And we love working with them. And they have access to these pathways. They're involved with the implementation of it too. So it's interesting to hear the comments about training our replacements. Another anesthesiologist said, my patients already do great with my care and this limits my options. And I will also point out with how Dr. Emil said that a lot of us have maybe some misconceptions about the quality of care that we're bringing or the standardization of our care that we're bringing. And when you actually look at the numbers, that they might be really surprising. And I think a lot of us do have this assumption that we're given absolutely excellent care to our patients, very thoughtful and patient-centered care. But it really takes the data to double check that to make sure that you're doing all of the appropriate things. So this is, every one of these things is something that somebody has said to me. Another time we were wanting to introduce blocks or a regional anesthetic technique into a surgery to hopefully add an extra layer of pain control for patients and maybe optimize their post-operative experience. And the surgeon said, like, we have too many cases to do. We got to keep the ORs running. This takes too much time. We'll just stick with the PCA or whatever IV-based medication that they were going to use, with those other unintended side effects of that. So again, we're starting to increase our regional anesthesia use in a lot of these pathways, and they are making a difference. And then, other global things, does this really make a difference, or how can these small things matter? You have to be prepared to have an answer for all of these questions because they will happen. People are skeptical because change is hard. And then lastly, I will say that we heard these comments very regularly at the beginning of the process, and this was several years ago. And I can't tell you the last time I've actually heard a comment that was negative about ERAS. It took time, and as more and more people got involved with it, the cultural buy-in increased, and now it is more of an automatic process. It's more streamlined, and the buy-in is there. Thank you for your time.
So in the interest of time, we will request Dr. Taylor to answer question and answers in the chat box or Q&A box. And I will move on with my presentation, which is basically the devil is in the details. So after the beautiful presentations that we've had, I will share with you what we do. Of course, this is kind of an adult protocol that we use, but can be modified for pediatric cases. So at my institution, we've been using ERAS since 2014, believe it or not. It's been a decade now. It's very well received in adult population, especially gastrointestinal surgery and neurosurgery. Sadly, we haven't made much headway in pediatric population. So the one that I'm going to present is for the ERAS for the Chiari decompression surgery, which is done at the back of the neck, and they remove the back arch of the C1 vertebra to relieve the compression. The biggest problem is the post-op pain. It's really pain in the neck, so to speak. So we are a major center for Chiari surgery nationally, and all the blue states that you receive, we get patients referred to us from those states. So we pretty much cover the entire country for Chiari. We started this program somewhere in 2009, and as you can see from the upward trending graph, we have really done well and grown leaps and bounds since we started. So far, we have done the youngest patient 8 months, and the oldest patient has been 60 years. So we cover a wide range of age group in these patients. So basically, our Chiari decompression protocol covers 16 and above. And as I said, we sometimes modify it to suit younger population. It consists of about 35 elements. And as you can see here, the ERAS protocol starts from home. The goal is to decrease the NPO time without compromising safety. So decreasing the NPO times does two things. It optimizes patients' metabolic status, and it's a better experience for the patient. Again, as Dr. Taylor said, it's a living document and is constantly undergoing modifications. So recently, we're finding a lot of patients coming with GLP-1, SGLT, and the NPO timings are completely different. So we are in the process of modifying the NPO times accordingly. The next phase is the pre-op. When the patient comes to the pre-op area, they're pretty much given two medications, Lyrica, that is pregabalin, and acetaminophen. The intention of giving these two medications is to decrease the post-op burden of the opioids. As you know, opioids have many complications. So if you can decrease the amount of opioids, that's the best thing you can do. For the patients who complain of PONV, we either give scopolamine patch or we give a medication called as a MENT. When it comes to intra-op guidelines, most of the intra-op guidelines, I would say, are generic that we usually do and are pretty much common sense. But I would like to point out to you the biggest impact that has been made on the post-op pain is by use of methadone in these patients. So we give methadone 0.2 milligrams per kilo. In younger patients, we, of course, decrease the dose of methadone. When we give methadone, we do not generally give any long-acting opioid intra-op. We give Decadron and ondansetron for PONV and the rest of the things as needed. Since we don't do nerve monitoring in these patients, it's okay to use a paralytic agent. In the post-op, the focus is mainly on four things. One, maintain hydration, maintain good urine output, advance diet as needed, and encourage ambulation. So these are the four goals that need to be met. So as you can see here, this is a very busy slide, and for a reason, because the post-op pain control is a major issue. So we had to get input from our pain department how to go about managing the pain in these patients. So we do dilaudid PCA, which is a hydromorphone PCA, and the goal is to transition the PCA to PO medication in the first 24 hours. We really push for it. And the PO medication that we use is oxycodone. To prevent the muscle spasms, we use Flexeril. The patient whose dura has been cut, we use dexamethasone. If the dura has not been cut, we use Celebrex. And of course, we use Tylenol and Colace. The last phase is discharge readiness. We find patients ready for discharge when they're tolerating liquid diet, when they've completely transitioned to PO medications, so their intravenous line can be DC'd, they're able to ambulate safely, they don't have any pain, and they're voiding normally. And these are the discharge medications they are generally discharged with. And we have found a great success, and we have been able to decrease length of stay from 3 to 4 days to 1 to 2 days. And most of the patients generally do very well. And this is our commendable super team who has made the ERAS in Chiari a success. That is our surgeon, Jeffrey Greenfield, and these are the nurse practitioners, PAs, who have really, really helped us in making the ERAS protocol a success. With that, I would hand over to the concluding remarks from our team. Thank you.
Thank you for our all speakers, very precious speakers that enlightened us about this very current topic. We have lots to ask and answer, I think, or discuss, but we have time limitations. So I think we have to conclude our journal club this time, but please keep on following us. We will be with you in some months with other topics as well. Meanwhile, I want to invite all our participants to the WCA the World Congress of Anesthesia, which will be held in Morocco in April next year. Please join us. Send your abstracts. The abstract deadline is still going on. So please join this big family of world anesthesiologists and pediatric anesthesiologists. Hope to see you again, and thanks to all our moderators and our speakers for all your contributions. Thank you.
Thank you.